طلعت الشاشة يا شباب.
ايوه واضحه.
طيب السلام عليكم ورحمة الله. اليوم حنتكلم عن موضوع I'm sure all of you by now الليفل اوف fellowship انتوا اللي فيها دحين آخر سنة ولا ايش؟
كل الفيلو دكتور من F1 ل F3.
ممتاز. يعني فهذا التوبيك مهم لكل الليفلز. I assume as more senior you go, you know that it's part of your practice سواء in the past and in the future, not necessarily حتى لو رحت أي تخصص. For me as an interventional cardiologist, I still use it because we see a lot of patients in clinics, one public or private, for this same purpose, to identify the patient at risk for CAD and to try to educate and eliminate, i.e. اللي احنا بنسميها primary prevention. As I mentioned earlier, the talk يعني ما هو 2 hours talk, it's probably half an hour, 45 minutes talk. We're going to stress on the most common things that you already know. And at the end, I'm going to give you a piece of paper that is actually highly recommended to read, which helped me and helped me also to update my knowledge about primary prevention and coronary artery disease. I don't mind both ways, either to interrupt and ask a question, or at the end we answer all the questions. Both ways are fine. So welcome everybody, and I share that your enthusiasm that it's in a weekends and you early morning, and instead of relaxing and doing something you like a hobby, to attend to some boring lecture in the morning. Right. Why primary prevention is important? As you would imagine, it's a major healthcare burden, and from Vision 2030, cardiovascular disease is there, and إنشاء مجلس القلب الوطني is one of the goals to eliminate and to reduce the risk. لأنه unfortunately Saudi Arabia is one of the highest countries that have mortality related to coronary artery disease, not because and it's because of a lot of multiple factors. احنا sedentary lifestyle because of our environment والculture والshift in lifestyle that we had over the past 50 years. بالإضافة احنا as Saudis or in the Middle East, diabetes is a major disease, and I believe in one survey it was 1 in 4 في السعودية they do have risk of having diabetes, either diabetes or glucose intolerance or insulin resistance. So the burden is real and the burden is huge, and the market will need cardiologists despite the amount of cardiologists we have in every field, in all the subspecialty, because the population is blooming and the disease is getting actually more and more, not less and less. And the aim, inshallah, with having a good healthcare system is to try to stall and reduce this disease that is #1 killer worldwide and #1 killer in Saudi Arabia, to a halt, and to at least reduce the risk and to reduce the disability associated with it. It's been studied multiple times that modifying the risks, and it's been shown in multiple registries. The biggest one that you would know is the Birmingham Heart Study Group from Boston, where they showed that reducing or modifying risk factors can lower the incidence of coronary artery disease up to 85%. And this is not expert opinion; it's observation of a 3-generation of Birmingham city population, where they saw if they altered the risk factor that we're going to discuss in the next few slides, what would happen to these patients. They do significantly reduce the risk factors. Also, there was a neat study that followed practicing nurses in the US for 10 years, and they found that reducing the risk factors, again, we're going to discuss in the next few slides, does improve outcome and reduces the risk of coronary artery disease. And this slide is actually taken from the World Health Organization, and everybody can have a look at it. You can determine the country, the year, and the cause mortality, all cause mortalities in that area. So here in Saudi Arabia, as you can see, 2017, 18, and 19, the #1 killer still is, and it will be for the next few years, the ischemic heart disease. Also, of this topic, what you can notice also that is outlier in Saudi Arabia only, road injury is high, and it didn't change much, but it is high compared to the other countries where traffic injuries is not high. And as you can imagine, all of us are driving, and you can see how crazy people drive in the street. So I think these two diseases, I think the government and the Ministry of Health are focusing on to reduce the health burden in Saudi Arabia, the traffic, and two big killers, the stroke and ischemic heart disease. طبعا it can be a little bit overshoot of these numbers, mainly due to تعرفوا في الديث certificate لما يكتبوها الشباب في internal medicine or even you cardiology, they write the reason of death is cardiovascular arrest. طبعا everybody dies from cardiovascular arrest, but is it the heart disease that killed the patient or not? Despite this fact that we know that maybe there is an additional number of patients due to ischemic heart or due heart disease, I still believe that ischemic heart disease is the #1 killer. And as you can see here in the United States too, the top healthcare in the world, they do still have, despite all the effort to reduce with modifying the risk factors, with the knowledge they have in their own local data, they do still have the ischemic heart disease as #1 killer. So as you also know, there are risks that you can modify and risks that you cannot modify. The non-modifiable risk factors are age. As you advance in age, the more likely you'll have coronary artery disease, and it's a fact of life that you will atherosclerose your coronaries and other vessels. Because once you eat meat at the age of 2 or 3 or start to introduce fat in your diet, LDL will be in your circulation. And that's part of the revolution that human had. And when the LDL is in the blood, it will precipitate, because it's a small particle, as you know, in the pathophysiology of atherosclerosis, it will precipitate in your vessel walls. And with time, it gets calcification. The factor that alters this rate of deposition, it depends on many other factors, like the lifestyle of the patient, any family history of lipid disorders, smoking, physical activity or not. These will make the curve more horizontal or more vertical. And unfortunately, in Saudi Arabia, I've seen people as young as 20 and mid-30s to have a significant multivessel disease, and their only risk factor is probably life modifiable risk factors, not like we know that in the Middle East and maybe Southern Asia, they do have genetic predisposition for CAD. In Saudi Arabia, luckily, I don't see it a lot, but we do have the tendency to have other diseases that can increase our CAD, like diabetes and hyperlipidemia. Obviously, gender, the male are more prone to have coronary artery disease than female. And what I notice also when taking the history, which is also, this is important for the clinical practice when you do history and physical examination, what do you call a positive family history of CAD? A lot of people would say positive family history without truly knowing what's a positive family history. A positive family history has to be at a certain age group, because if your grandfather had a heart attack at age 70, that's not a positive family history. It has to be specifically, and that's important when you verbalize it in the note that you're discussing with the consultant or with your colleague, that you say family history of premature coronary artery disease, and the usual age group as been quoted by studies, 55 for male. Anything younger than 55 in male or younger than 65 in female is considered positive family history. Beyond that, it's not positive and it's not a family history. To make it easy and confusion, 55, 65, just make it 60. 60 of any family member who had a heart attack, first degree family member who had a heart attack or heart disease is a positive family history of heart disease. Ethnicity, again, it's non-modifiable. You know, and you've been treating, I'm sure, the population, Bangladeshi, Indians, they do have premature coronary artery disease. Not only that, they have diffuse disease that's not amenable to PCR or cabbage, and they do have the tendency for premature atherosclerosis, and it's probably part of their gene pool that they can't modify. what are the modifiable risk factors? From the 1950s, the idea, I think because of they noticed after the World War II that it was the blooming years, they noticed that there was an increased mortality in middle age, because 60 in the North America is considered middle age. So they wanted to quantify to identify what risk factor. Back then, the smoking was social event and it wasn't even considered a health hazard, until the studies came after another showing that it is associated with cancer, it's associated with increased cardiovascular disease. And here is the sum of many, many years, at least 50, 60, 70 years of research, identifying either a causal correlation between these factors and coronary artery disease. Smoking, as all of us know, active or passive smoking can cause premature coronary artery disease. Obesity, not by the obesity itself, it's actually by the factors that comes with obesity, i.e. diabetes, sedentary lifestyle, glycemic index, hyperlipidemia. They found there also an association between waist in men more than 108 or 110 centimeter, in women more than 88 is associated with significant coronary artery risk factors. Diet, obviously, is a major play role in increasing and decreasing your carbohydrate and your lipid content in your blood. Physical activity has been shown in multiple studies that having a minimal activity of 30 to 45 minutes for moderate to severe intensity exercise can protect and can be cardioprotective. Obviously, then they found that the strong association between hyperlipidemia, hypertension, and diabetes, and the development of coronary artery disease via probably the process of atherosclerosis and narrowing the vessels. How would you do primary prevention? Secondary prevention, كلكم حافظين على الصم. You know how to treat CAD, and you know what's your goal and target for each and every level. We are talking today specifically about the primary prevention. Primary prevention meaning that you want to educate the population and you want to prevent coronary artery disease from happening. And most of these patients, you'll be seeing them either in the non-clinical setup, and as part of your family gathering, بيسألوك كيف نحسن our life, how to reduce our risk of coronary artery disease. And I've seen it mostly now in my private practice, where I see these patients coming after a friend who had a heart attack at a young age. So they want to make sure that they will not have the same outcome as their friend. And probably if they're a close friend, they have the same risk factor, meaning that they smoke together, they have the same eating habits, they have the same, and friends who goes to the gym, they will always go to the gym together, or at least encourage itself. So modifying these risk factors goes together for patients young in the population. And there is a recommendation and guideline that we're going to touch base in the next slide. So the goal usually is for therapeutic lifestyle changes, which we're going to discuss in each single one, and also primary prevention using some therapeutic agents. So you can't mention primary prevention without mentioning a big name like Salim Youssef from Canada, who is investing a lot of his research in finding the correlation between coronary artery disease and risk factors. And his study, that was a case control study published in the Lancet, the Interheart study, identify in different, as you can see here, 52 countries, identify without a doubt that the more risk factor you have, the more likely you have significantly risk of coronary artery disease, i.e. first, in his study, it was first myocardial infarction. Smoking, as you can see in the horizontal line, smoking, diabetes, hypertension, elevated lipoprotein. And if you have the combined of these three, as you can see, the trajectory is increasing. The more risk factors, the more likely an odd ratio you will have first MI in your 5 years of the study. And this was one of the cornerstone studies that showed the correlation, but you can't also mention primary prevention and not mention the Framingham Heart Study group, And this was their celebration of the third generation, where they studied. It's a small city in Massachusetts, where they studied this population after the World War II, where they take these patients and they do their continuous analysis based on history, multiple labs, and even investigations to try to identify and isolate coronary risk factors. And I think just recently in 2018, they celebrated their 70th year of continuous, and I think they had more than 2,000 papers published out of their data sets. And the Birmingham Health Study Group showed clearly that they could isolate five risk factors where they implement into their Birmingham risk score calculator that I encourage everybody to use from time to time for these patients, to give them a hard number on what's the risk of having a heart attack. These are the risk factors that they came out with: hyperlipidemia, smoking, obesity, and diabetes and hypertension. And as you can see that they quote their numbers in 10-year risk of having coronary artery disease. And having one of these actually can increase your event into up to 30%. This is also an important slide that might be important to have the idea why the governments, why the healthcare professional, why the funding should be invested in such an initiative, which is prevention of primary heart care, knowing that a treatment of heart disease is very expensive when it happens. And PCI, surgery, the whole package of it, it's very expensive, and it can be burdened to a certain population. And so, but tafkir al-logic, if you reduce these diseases, then maybe you would have reduced cost and improve outcome of your population. You can see in this curve, the black curve on top, I'm not your pointer, but you can see that there's black point of curve upstairs there, and showing that in 1948, when the Birmingham Heart Study Initiative came, and then the subsequent paper showing that yes, hypertension causes heart disease. So obviously, physicians started to be keen more on treating these hypertensive patients, giving them tighter control. Smoking is bad, hyperlipidemia is bad. You see the trajectory of death from heart disease in the US per 100,000 population. Significant reduction, and it was just by initiating the idea of primary prevention. So this is something that if you want to go at the level of the prime ministers or the Ministry of Health, to show them that prevention does help and does improve outcome. And this is the one I'm talking about, and they updated it now in their website. They have the 2018 prevention guidelines of cardiovascular risk calculator. This is for myself, although I'm not 40, I'm 38, but the lowest age they can start with per the Birmingham Heart Study is 40, and that was my risk. So do it to yourself, do it to your loved ones, do it to any patient who's coming to you in your clinic asking for an opinion about his risk for coronary artery disease. And then you can tell him, yes, you have a high risk, low risk. And it can be also helpful to screen patients where you want to see them in the next 6 months, or you want to see them after a few years of follow-up. It's very easy and user-friendly, and I'm sure you have also apps in your mobile that can show you how to use or how to calculate the Birmingham risk score. And as you know, Birmingham risk score less than 5% is, if the risk is for atherosclerotic cardiovascular disease in 10 years, less than 5, that's low. Intermediate between 5 and 7.5, and then 5 and 15, it's low, and then more than 15, it's considered high risk group. So now we're going to touch base on in each single of these factors, and then talk about what is recommended. Diet. I know it is tough to stick to a diet, especially with our lifestyle, the lifestyle of the younger generation nowadays. Just education about, which start at school, start at local schools, and also at the family level. that increase the fruit and vegetables, fibers, the usual generic prescription that we tell patients. Avoid fatty food, avoid fast food. There is no specific regimen. Yes, do keto diets or do calculate this and calculate that, because nobody will stick to that. Just give them the hint of caring, that when you eat your plate, if your problem is quantity, try to reduce the quantity. If your problem is quality, then try to choose wisely by increasing fruit and vegetables and fibers in your diet. Try to avoid high glycemic index food. Get the complex sugar that takes time for it to absorb so you don't feel hungry. Monounsaturated fat rather than trans fatty or saturated fat. Hydrogenated oil to avoid. Use animal oil is bad. Using vegetable oils is better. Omega-3 fatty acid is always good in the right quantities. So my approach usually for these patients, or for the prevention in general, is not to tell the patient stick on a diet, because nobody will stick on a diet for long. And it's been shown multiple times that sticking on a diet can be done only in trials and if there is a purpose. But in general life, nobody will stick on a diet. Just have that general bulbar thinking about keeping these gold pillars in your mind whenever you're making a meal. Smoking, not only active and passive smoking is bad. Obviously, active is more harmful than passive. The active smoking, you have to calculate it in months, pack years, and then convert it into months if you want to use the Framingham risk score. And the benefit of cessation will begin in few months after the patient stops. غالبية المرضى اللي أشوفهم دائما after their MI, when did you stop? He said, just now. Well, that's not a ex-smoker. He's still a smoker until I see his commitment of smoking cessation. The benefit can reach to the levels of the non-smokers in years. So the patient has to understand that the longer he became non-smoker, the better that he will become, and the more he will become to non-normal, to the normal population. Counseling on a regular basis is important. Also, this is from my personal short experience with these patients. I don't tell them to stop smoking. I tell them just set yourself a goal that you have the smoking by this month and subsequent months to reduce it more and more. Using the newer stuff like IQOS, اللي هو اللي ما يستخدموا فيه كبريت, I think, اللي هو just vaporizing this the nicotine can be, but we don't know the benefit or the harm. The vape also, we don't know the benefit or the harm, but it's been shown now that it's actually more harmful, as it gives the body more level of nicotine. So you solve the problem of the oxidation, the carbon dioxide, and the carcinogens, but you created another problem with the nicotine. Hypertension, first to diagnose patient with hypertension, and two, to treat. If the patient is not hypertensive, what I usually tell in Saudi Arabia, recommendation, more than 35 years old, you should measure your blood pressure at least once in a couple of years. And that by itself helps you identify patients who are hypertensive. Obviously, the diagnosis of hypertension is beyond the scope of this lecture, but you know how to diagnose hypertension. It's not one single visit in the clinic that show the blood pressure of 180 or 150 or 160 that make the patient hypertensive. You have to do multiple home reading of blood pressure on the right way, and or using the ambulatory 24 blood pressure monitoring to diagnose hypertension. And it's also important to educate the patient on how to do the proper blood pressure measurement, because most patients don't do it properly and they get falsely elevated or even low numbers that is giving false reassurance. The goals of treatment and the goals of numbers based on comorbidities, all of you know, if the patient is diabetic, 130/80 is the minimum target that you should achieve. If the patient is ischemic, even sometimes you would want to reach to 120. If the patient is non-diabetic and other comorbidity, maybe 140 and 90 is acceptable. In extreme age where hypertension is risk and maybe stroke is risk for patients, you would want 150 isolated systolic blood pressure. Starting with the non-pharmacological measurement with diet and exercise, which can help collectively to the same goal of primary prevention of CAD and help with treatment of hypertension. And then pharmacological treatment based on the case-to-case basis and patient comorbidities and the stepwise approach that you already know about how to treat hypertension. dyslipidemia, you follow the guideline and how to treat. What I noticed that there is a discrepancy between the American, Canadian, European guidelines. What I would suggest, stick to one guideline. Because I'm Canadian trained, I'm more familiar with the Canadian guidelines, so I follow them. So stick to whatever guideline you are. For the primary prevention of dyslipidemia, there is no such thing as just, يعني غالبية السعوديين, they have hypercholesterolemia of some sort, mostly in the intermediate range. However, there is a clear indication, there is a calculation, and there is a risk factor that you can calculate and determine if the patient would benefit from a primary treatment. Only one I want you to remember, that an LDL level above 5, for me, it's automatic statin therapy, because that would signify familial hyperlipidemia that will not be lowered by any lifestyle modification or diet. And statin therapy is indicated to achieve a goal of more than 50% reduction, at least, in the LDL. So LDL above 5 is usually indicative of the patient have some sort of hyperlipidemia, and treatment is usually indicated. Physical activity, again, and I've said it multiple times to all of my patients, I don't want you to go to the gym. If you go to the gym, that's excellent, perfect lifestyle. But if you can't, I want you to do the minimum that I require you to do, which is moderate to severe intensity exercise 3 times a week, 30 to 45 minutes each session. كثير من المرضى غالبيتهم female think that walking in the mall is just an exercise. أو المشي في الممشى على الكورنيش ولا في ممشى هنا ولا هناك is considered an exercise. This is not an exercise. In order to get the benefit of physical activity, you have to have an increase in your heart rate. Your heart rate should increase, should pump more blood, should create vasodilation and all the beneficial cascade that happens from exercise, which will not happen in casual walking while you're having your phone or walking for 2 hours. That's not an exercise, and it doesn't count as a physical activity that would reduce your risk factor. You have to pump your heart rate. You have to increase your heart rate to a certain level, usually in the 120s range, to achieve the benefit of exercise. I want that to be in a 30 to 45 minutes, 3 times to 4 times a week. And this is something that you should tell your patient, because that misnomer that walking casually is an exercise is wrong. And it's أضعف الإيمان, but there is no benefit out of it except that you are going to change يعني تغير الأوضاع فقط بدون ما you will not get any benefit from casual walking. Weight loss, as we mentioned before, waist of 88 in female and 88 centimeter in female and 110 in male. More than that is usually associated with significant increase in cardiac risk factors. So try to achieve less than those numbers, plus maintaining an
دكتور خالد، شكله الشيرنج قفل، شكله انقطع اتصاله، بس دقائق كده بيدخل معنا.
السلام عليكم. شكله انقطعت
اي عند الاوبستي.
اوكي، طيب نرجع لكم نسوي شير السكرين. شكله الريسبشن عندي ضعيف كان. طيب الويت لوس. فزي ما ذكرنا انه maintaining a goal BMI is important, and it's been shown in multiple studies that it reduces coronary artery disease significantly, not only by the weight itself morphologically, but by reducing the risk of other risk factors like diabetes, dyslipidemia, and insulin resistance. Diabetes is very common, as we mentioned, in Saudi Arabia. You want to have a glycemic level around 7 to reduce to be able to reduce the risk factor without compromising the patient's glycemic control. طبعا الاسبرين as the primary prevention, it's a big debate. كل سنة تطلع paper debunk the previous one. Meta-analysis that showed that might be beneficial for certain subpopulation. Some that would deny it. So my understanding of, you can have it different, but I think the most society nowadays saying that no, in general, for aspirin as primary prevention. However, if the patient is at risk, that's my usual personal approach for these, because we do have a lot of patients who take it over the counter in Saudi Arabia. What we usually tell them that if you are over 40 years old and you have lower breathing risk, with maybe potential benefit of colon cancer if they have family history of colon cancer, because as you know, in this meta-analysis, it showed that taking aspirin daily reduces the colon cancer risk. If you are this patient who are not at high risk of bleeding, definitely, and have low and have maybe risk factors, diabetic, overweight, has family history of CAD, then it's not unreasonable to start aspirin. I think it can be started on the dosing between 75 and 100 milligram daily. And I don't think he would be at fault by giving this patient, and he can stop it at any time if bleeding would have happened. However, the routine use is never an indication, and now you can't use it automatically, especially for elderly patients above 70, because multiple observational studies showed that over 70 years old, if you're taking aspirin as a primary prevention, your bleeding risk is higher than the benefit of reducing ischemic event. Omega fatty 3 acid, again, there is multiple patients that come to me with omega-3 fish oil telling me, does it help reducing cardiovascular risk factors? Actually, most of these bottles available in the market are not. يعني only one brand of ethopropanol حتى ما أعرف الاسم حقها, and I lost track of it, so I just tell patients not to take omega-3 because of the lack of really associated benefit between taking these pills, over-the-counter pills, with and cardiovascular disease. However, a good healthy lifestyle, knowing that if you eat fish, specifically fish rich in omega-3 like salmon, sardine, الكادز والكان تونة حتى الموجودة light white tuna can be beneficial and a good replacement at least twice a week. Can be beneficial, especially for the young populations and teenagers, as it would be a good supplement of omega-3 fatty acid that comes mainly from fish oil. Taking the fish oil tablets, it has to be in humongous dosing, because most of these dosing they take, because they are in tablet form, they will be flushed away with the stool, so they will not get the benefit and will not get the absorbance. Plus, it's really tastes bad. I don't know if anyone tried it. It tastes bad and it makes you smell like a fish. So I wouldn't recommend it. And even the guideline wouldn't recommend taking them, except for this recommendation, which is having a good healthy diet of salmon and other fish that has omega-3 fatty acid would be beneficial and primary prevention of CAD. I'm going to finalize my slides with this slide of the 2019 American College of Cardiology and conjoined with the American Heart Association guidelines for primary prevention of cardiovascular disease. For those who are going into taking the exam soon, read this paper, memorize it, because most of your questions, if it will be from guidelines, it will come out of this paper. And it's stating the obvious and exactly what we mentioned in the past few slides about how and when to primarily prevent cardiovascular disease, and what is meant by every single thing, like what is a diet, what is the exercise prescription that you give to these patients. That concludes that. There is some snapshots of the most common things, but I think I leave it for you to read, because just versing it to you will not have the aimed benefit. I'll be more than happy to answer any questions, and I thank the organizing committee for their invitation. Again, it's a very, very light talk, but important, and something that you will see in clinic and in your day-to-day activity as a cardiologist, inshallah, in the future. Any question, Shabab?
الله يعطيك العافية دكتور خالد, جزاك الله خير. So I have a question, just to take your opinion in that. You know, in the media nowadays, there are some talks about the association between lipids and the cardiovascular, and some people are saying it's not associated, although all the studies are very clear. Like, how you take that, and how do you answer that in a professional way?
Well, the Saudi Heart Association, actually, they issued a paper clearly. And هو أصلاً pediatric cardiologist, to cut into the point, pediatric cardiologist في الشرقية, who comes عشان يبحثوا عن الموضوع, والله أعلم إيش نيته. They just want the show probably. They are saying إنه الكوليسترول ما بيسبب heart disease. We've been seeing it multiple times, and if you've been into the OR, if you've been into the cath lab, you see atherosclerosis. And we know in a pinch at the post-mortem how atherosclerosis form. You can't debunk this many years of research with someone who's saying eating cholesterol will not cause an elevation in LDL. We know that patients who take fatty diet for a long period of time, it's a complex interaction. I give that some patients يقول طيب واحد عمره 40 سنة طول عمره بياكل ذبايح في الأسبوع مرتين ثلاثة والكوليسترول حقه normal. Yeah, maybe he has a good liver that can desensitize an LDL and make his LDL level to normal. Some people are lucky to have that. That's why it's a polycomplex interaction between your environment, yourself, your biology, and medication if it happens. You can't argue with science, so you answer them with science in a respectful manner. Any opinion is well taken. And most of them, when you show them the evidence, show them the science, هيجوا لك على مبدأ الأرض مسطحة والأرض قوية. the same analogy. اللي مؤمن إنه الأرض مسطحة لو تجيب له تمسكه وتعلقه فوق الأرض وتوريه إنه الأرض ما هي مسطحة, they will not believe. You just educate patients and to the best available information we have. We might in the future find that we are wrong, and that's the beauty of science. Once we know that we're wrong, we'll stop and we retract everything that we learned. And that's what evidence-based medicine is.
يعطيك العافية دكتور.
الله يعافيك ما شاء الله.
دكتور عفوا ممكن سؤال؟
تفضل أكيد.
بالنسبة للإلكترونيك سيجاريت I don't know بقرأ عنها بس ماني عارفة we will advise for the cardiovascular لأنه في ناس ما حيبطلوا أو لا إنه ما في benefit, فكنت أبغى أعرف.
As you mentioned, it's a new topic. زي COVID. We don't know if COVID is strongly associated with prolonged fibrosis في future. We don't know. فالفيبز والالكترونيك سيجاريت ما احنا الايديا انه احنا we know how smoking causes CAD by multiple factors, nicotine and carcinogens. Having eliminated some of the bad thing in the smoke, in the cigarettes, by taking it as a nicotine, doesn't eliminate the bad effect of nicotine itself on the coronary artery and accelerated atherosclerosis. As you all know, smoking, what I always also tell the patients, لما حتى أسوي له coronary artery after a positive stress test and he's only a smoker and I found a normal coronary. What's the pathophysiology of smoking causing angina? Well, we know that, and it's a fact, and it's in the labs. Multiple time it was done and proven that smoking prevent the release of vasodilator from the coronary artery smooth muscles, i.e. prevention of vasodilation that happen physiologically when you exert yourself. And humans are a dynamic individual. They walk, they exercise, they run. So when they run, there is nitric oxide that is released and then vasodilate, so it can keep up with the oxygen requirement because of the increased activity. And smoking cut that into, prevent the nitric oxide relief. It will lead for the patients to have a fixed coronary, yet ما في atherosclerosis, but has a fixed diameter of the coronaries because they didn't dilate to accommodate an increased demand, and they have angina. And usually this also goes deep into the level of the microvascular and endothelial dysfunction that smoking can have. And I do believe that cigarette smoking does have even partial effect with this pathophysiology, leading to the same problem, maybe less, and maybe things that we'll explore in the future. But I would say to the patient, yes, it is there. It could be less, but it is there. So you can't advise the patient to. I can use it as an alternative to heavy smoking. Like إذا أنت ما تبغى يعني كأضعف الإيمان خلاص تتخلص على قد من smoking itself to something less, maybe. But I'll tell him honestly, I don't know if that will create oral cancer or lung disease in the future that we can't treat. Okay.
يعطيك العافية دكتور خالد. استفسار له أنت، بسأل على الأنيمال فات. يعني تعرف احنا ككلتشرال ايشو في أي study أو شيء يعني comparing different type of animal have less toxicity to the cardiovascular ولا لا؟ يعني إنه مثلا إحنا دائما ننصح بالوايت ميل بالوايت ميت بالفيش، لكن يعني ككلتشرال هم دائما يسألون هل الكمل، هل الخروف، البقر أفضل من ناحية التوكسيسيتي للهارت ولا لا؟
Well, without a doubt, we know في studies, yes, and animal fats are bad by elevation of your when ذكرتها في one of the slides that you want to have the mono unsaturated fat because the trans fatty acid الموجودة في الانيمال fat, الsaturated fatty acid الموجودة في الانيمال fat is a leading cause of atherosclerosis and elevation of LDL. طبعا زي ما ذكرت لك, it's a body interaction, multiple interaction on many levels on the patient amount of how much he takes and his genetic base or background. If his liver can detoxify this, can alter the PCSK9 receptors الموجودة في الجسم that can increase or decrease the LDL. So it's multiple interaction level, but it's known that fat from animals is bad, and it actually the main factors for hypercholesteremia, i.e. hyperlipidemia and hyper LDL, the main risk factor for CAD. So without a doubt, yes, animal fat is bad. Animal oil, plant-based oil is better, specifically olive oil.
الله
يعافيك. الله يعافيك. The usual what I tell patient لا تقطع. ما حد يقدر مثلا ما ياكل مندي لحم بين فترة وفترة. Just try to cut it. When you see مثلا لحم في دهن, شيل الدهن أو شيل جزء منه. وزي ما نشوف بعض الناس يقطع الدهن وياكل الدهن بنفسه, ياكل الشحم بنفسه, which is unhealthy.
الله يعطيك العافية دكتور خالد.
الله يعافيكم يا شباب. فرصة سعيدة. أنا في بعضكم ما أعرفه صراحة. إن شاء الله نقابلكم في الرياض وراني في سعودي هارت أسوسيشن ميتينج. طبعا أنا الباك جراوند حق interventional cardiologist في جامعة الملك سعود. If anyone needed anything in that regard, I'll be more than happy to support.
دكتور في question على الشات. What is the stronger risk factors associated with coronary artery disease?
Strongest?
Yes.
it's this smoking is the strongest predictor of coronary artery disease and hypercholesteremia after it. بس طبعا هي كلها combined. يعني you can have a smoker who will never have a CAD, and you can have a hypercholesteremic who doesn't have a CAD. But the top two that if you want to choose, and لو مريض قال لك أي اثنين أقدر أسيطر عليهم و I will lower my risk, is smoking and hypercholesteremia.
الله يعطيك العافية دكتور. I think no more questions.
Any more questions? حياكم الله. If there is any questions, أنا active on Twitter. I'm active, available everywhere. أنا موجود جامعة سعود. If you have any questions, any concerns, any projects, feel free to contact me. I'm open to all. بالعكس, it's part of my duty to you guys. وأنتم المستقبل. أنتم future cardiologists إن شاء الله.
I have a question if you don't mind.
تفضل.
That's the question. Sometimes we face a patient after coronary artery disease that their lipid is not that high. I mean, it's not really high, and they are not smoking, not diabetic, not hypertensive, and then they ask you question why I get it.
صحيح.
I do believe these patients, they have underlying some lipid disorder, but obviously it's not there. So usually we stuck with those patients and we don't know really how to tell them about it. So would you tell me if you face this,
okay.
how would you?
Well, the numbers don't lie. يعني if it's a true sample that was repeated multiple times, طبعا ندخل في الدبيت حق fasting and fasting. I usually ask for non-fasting for all my patients because there is no difference. That's another talk. But if the numbers are true and they are low, can be low for many factors. Can be low لأنه المريض أصلاً بعد ما جته الجلطة انصدت نفسه ما صار يأكل زي أول. اللايف ستايل تغير. Can be low from other factors that the patient is sticking on therapy. وأصلاً irrespective of the LDL level, you would start treatment. That's secondary prevention, not primary prevention. Secondary prevention, irrespective of the LDL level. هذا الرول لازم تحفظوها وتحطوها حلقة لكم. Patient who are diabetic above 40 years old, يعني طولوا على diabetes, يعني they have prolonged diabetes, they should be automatically on an statin therapy because of the benefit and the reduction in atherosclerosis. You want to stop the atherosclerosis. Even if the patient have an ACS, a STEMI, and his LDL cholesterol level is 2, i.e. reach the target, I don't care. I want it 0. أنا دائما أقول للمرضى I want it to reach as 0 as possible because there is multiple observational studies. نسيت اسم الstudy, it doesn't come to my mind, but it showed that the lower the better. At the target, as you know, it's 2 and sometimes 1.5 of an LDL level to be achieved post-STEMI or post-DCS population. So and I tell the patient, and I know منك hypertensive, بس أنا أعطيك ACE عشان remodeling of the LV to prevent LV remodeling that will make your LV dysfunctional. I give you statins not only to lower down the cholesterol, which you are already achieving, but I want to stabilize any plaque that there is. We know that the plaque that happens and cause the STEMI or ACS is the 10-20%. And this is, you will never see it because unless you do intravascular imaging and see the atheroma. So the benefit of giving these treatment irrespective, yes, we have numbers and target to reach, which is good because there is a correlation between achieving these numbers and good outcome. But irrespective of this number, tell them the patient there is benefit of taking this medication as a secondary prevention. حتى لو كان ال LDL حقك 0, you will benefit from this. Lastly, I tell the patient, and it's the fact that lowering the LDL cholesterol level now have an implication in your 10-20 years from now, not now. يعني البنفيت اللي هتشوفها الآن almost nil. But the benefit when you are 20-30 years older, that's when you will see the maximum benefit of what you did when you took the statins, even when your level of LDL was normal. حتى هذا البراكتس حقي لما أشوف واحد 90 years old, multiple comorbidity, I stop the statins لأنه the benefit ما حيعيش حتى يشوفها. يعني when he's 100, he will not maybe reach 100 to give it. And that's for extreme age. I don't give statins high intensity. I give it homeopathically, like 10, milligram, or if the cholesterol is truly, truly high. Hopefully that answered the question.
Thank you.
If there is no more questions, I see everybody is leaving. Again, as I told you, I'm approachable by all the means of communication. You have my emails, and you have my Twitter account, and you have my, I'm physically present for King Saud University, for Riyadh. If there is any questions before the exams, any